Hello.
Hello.
I was wondering, usually everybody's in a little early. I was like, wait a minute,
I was gonna say I'm the first one.
yes, sometimes something happens with the Zoom link. And so I was
Yeah.
actually ready to post it again in the class in the course room just to make sure. Because usually people are in by now.
Yeah, I was freaking out because I'm usually in here by at least 50.
And I'm just gonna post it just to be on the safe side. Okay, well, people are coming in now, so maybe I don't need to post it. Okay. Okay. I was getting a little worried. So we do have 6 minutes, so we have a little time. I'm just gonna mute myself so you won't hear me moving all this stuff around. So good evening to everyone. We have 1 minute before, well, probably less than 1 minute, probably 30 seconds. Ensure that you have placed your name and your campus in the chat. And I will place the time when it turns. Ensure that your cameras are on. All right, it is 5 o'clock and we will officially go ahead and get started. But go ahead and place your name and your campus in the chat. As a reminder, all cameras need to be on. All cameras need to be on. And even if you have to step away for just a few minutes, restroom or to get some water or something, your camera needs to remain on because that counts against you as far as your time being on the camera. So just leave your camera on, put me a message in the chat, ensure that you select me so it doesn't go out to everyone. Just as a reminder, these sessions are recorded and are viewed by administration. So just to ensure, and that's for your safety as well as mine. So I like to just provide that reminder every time. So it's still showing as, well, 5 o'clock my time, 6 o'clock you all's time. So go ahead and place your name and your campus in the chat. How is everybody doing today?
Long day.
Long day. Okay.
Tired.
I know. We're almost through the week. Well, we have what?
Yeah, we have exam tonight too.
Oh, in your next class?
Yeah, peds.
Ooh, okay. Well, you all, I just want to say, I am so proud of you all. You all did really, really well on the first exam. Those of you all that I met with one-on-one, you did identify what you could have done differently. For the most part, it is not that you do not know the content and understanding the content. It is you identifying what that concept is. And like I say, for lack of a better word, matching what you know with what they want you to actually answer in the question. But overall, you all did really, really well. And like I said, just so proud of you all for doing really good that first exam. I am still available for tutoring going forward and, going backwards, reviewing that exam just so that you can get an understanding of what you did not get correct and your why. Some, and for the most part, I think maybe only 1 or 2 y'all were wondering about the exam results. But just as a reminder, we review exam results as a team. We go question by question, and that is to your advantage. You don't want the exam results right then when you take the exam. You want us to review each question one by one, because what happens sometimes, the question might not be worded correctly, the answer choices might not match, things happen. And so when we get together as a team and review that, all of those things are looked at. And if the question, as a team, we decide that it's not worded correctly or the answer choices, they don't match or something's not, matching there, then you all receive full credit for that question. So, but for the most part, everybody, I guess, have gotten accustomed to, hey, we'll get you the results, but that is our why. It is to protect you. It is so that we can go over and just to ensure, because even though we put those questions are put in, sometimes things happen. And so, again, tutoring going forward, I am still available. Send an email or a text message so we can coordinate some time. You'll be surprised. I think we were on last night, probably as late as 8 o'clock my time, 9 o'clock other students' time. And it doesn't take that long. We can do Zoom, over the phone, or however. So just know that I am there for that. For those of you that scored less than 78% on the exam, remember, we should be meeting weekly. So just keep that in mind. It's nothing but just touching bases and just going over a few concepts. It's nothing that you have, it's not a long, extensive meeting. It could be an email back and forth. Hey, just checking in on you, because weekly we turn in those reports to your deans. And again, it's just there to protect you, so that in the event that we need to work on some different things, that we can identify that. So moving forward, that you can be successful in this course, because remember, you have to have a 78 KGA before all the other tasks and assignments are factored in. All right, so any questions about anything that I've said thus far? All right. And so, well, let's just move on then. So week 3, we did post a recording, even for week 4. Credit to Dr. Lundy. Her recording was there for week 4, but what we're going to do is toggle back to week 3 just to ensure that we've gotten a good understanding of all those concepts, and then we'll move forward with week 4. We do have an interactive activity, Jamboard. Are you all familiar with Jamboard? So we're going to use that toward the end. But nevertheless, let me go ahead and share my screen here. Let's get started. Again, if you have not placed your name and your campus in the chat, please do so. And let me share my screen here. So first off, let's talk about, I'm just going to do slide by slide. I won't do the slideshow. Well, I'll try the slideshow. We'll see if it works. So what are risks? So what is our understanding of what a risk is? Are you all seeing my screen?
Yeah, I got a question though. I see your screen, it says risk, but is that a chapter that you're in, or is this just your slideshow?
No, this is my slideshow.
Oh, okay.
But it's from all of your, your readings and your assigned.
Yeah, because I got the chapters in front of me. I just wondered. Okay.
Yes, this is something I'm always creating something to just kind of get along.
Okay.
I'm always trying to narrow down and focus in on things. So if I do like a live recording, or if I have a PowerPoint or something, I'm just trying to narrow down on those concepts, just ensure that you have a good understanding of this. So no, this is just something I've created. But it comes from your assigned readings. So risk, you all, what is a risk? What do you think that is?
Are you talking like a risk, like as far as like health? Like danger?
Yeah, like what is a risk from A to Z? What is a risk? Whether or not we're talking about a specific disease process, whether we're talking about violence, what is a risk? What is our understanding of what a risk actually is?
A possibility of something happening.
So go ahead.
Something, sorry, risk, probably like something that you're susceptible to.
Okay. And this is a little, I'll say this, but just put like a small pin in it. So sometimes, for the most part, when we say the word risk, it is something that a negative outcome that we do not want to happen. But sometimes risks are not so negative. I don't want to say that they're positive, but sometimes risks are not so negative. For example, just think about medications. You see, if you've got your little printout from the pharmacy, that medication is to help, we'll just say high blood pressure, but then they have a 10-page book that you have to take out of there because it could potentially cause or put you at risk for all these other things. And then on the flip side, they have medications that were designed for, we'll just say high blood pressure, but then it's actually used for a whole different disease process. So sometimes risks are negative, and then sometimes they're not so negative. So someone respond to that. Do you understand what I'm trying to say about the risk? Diane, looks like you're talking, but I can't hear you.
I wasn't.
Oh, okay.
Sorry.
All right. So I need to hear from you. Remember, this is, it's interactive. It's not just me talking. So have you all heard of medications that are being used? They said off-label use. Have you ever heard of that? Medications being used for something other than what they were intended for?
Yes.
Yeah.
Okay. So that's my example of risk not so negative, but at the same time, it can still potentially cause us harm. So when we're thinking about our interventions, we have to keep in mind, what are those risks? What could potentially go wrong? More so the negative side. And then how can we reduce those risks? So that's when we come into our different interventions, our primary interventions, our secondary and our tertiary interventions, risk reductions. What are some things that we can do? And it didn't have to be related to any topic. What are some interventions that we can do to decrease risk or cause risk reduction?
Well, just like you said,
Education.
primary teaching, the education, yeah.
Mm-hmm. Mm-hmm. Okay. So education. And what about if it was a injury that has already occurred? How would we prevent exacerbation or further risk or complications from happening?
Follow-up care.
Follow-up care, we encourage them to follow up. What else can we do?
Or just getting therapy sessions or like, I don't know what you call them, rehabilitation therapy sessions.
Mm-hmm. Whether or not it's PT, OT, whether or not it's counseling, exactly. And so that helps us think about the different levels of prevention and also, hold on, let me turn this. So that helps us think about the different interventions that we might have to actually do or suggest to our patient or our communities. I may have to stop sharing and hold on, let me stop sharing. Every time I try to do the slideshow, for some reason, my computer does something strange with the PowerPoint. All right, so let me share again. So any questions about risk? So I think you all said it. Health risk reduction, health risk can be reduced through a variety of approaches. That's our different levels of prevention. Health risk reduction is based on the assumption that decreasing the number or the magnitude of risk will decrease the probability of an undesired event from actually happening. Whether or not it is alcohol abuse, whether or not it is preventing or detecting early breast cancer, no matter what it is, A to Z, it is decreasing the probability of an undesired event from happening. Okay, so we're going to talk about two different health risks. This one, alcohol and drug use among adolescents. So let me hear from you. So what would be some primary prevention interventions, secondary or tertiary, when we talk about alcohol and drug use among our adolescents?
Primary would be education.
Alcohol away, like out of the house.
Okay.
Parents talking to the kids.
Mm-hmm. What about if the child already has an established problem with alcohol and drug use? What level of prevention would that be? And then give me an example.
Tertiary, and it'd
Okay.
be already like sending them to a drug rehabilitation place or.
Good. Okay. Good. So we said the parents not drinking, making sure that alcohol is not available in the home, having those discussions about potential adverse effects of using those drugs and substances. Good. Okay. So let's talk about 16-year-old preparing to get their driver's license. What are some interventions, primary, secondary, or tertiary, to prevent something happening, an accident or something happening after that 16-year-old actually gets their driver's license?
Education on safety, not
Mhm.
using your telephone while driving,
Yes.
no
Tell them not to
texting.
drive and text or play on their phone, I guess.
Okay. So what about secondary? What's something that we could, because secondary interventions are when we are actually doing what? What are those words we say? What we use to describe secondary interventions?
Is that the screening? or-
Screening.
Screen.
So would like driver's ed be screening?
It could be it's on the next slide, and that's what I was leading to. Driver's ed is it could be really secondary and tertiary. It really could be. So that's good. Put a pin in that. So what else could we do for secondary? So we're screening.
What about like the apps that you use to like monitor that you can monitor their speed?
Okay. So parents can download an app, keep up with
Or
their,
like Progressive, they have those little things that you stick into the car that monitor.
the speed.
Mm-hmm.
Okay. Okay. All right. Good, good. So, okay. So let me hear from you all. Where do you all think driver's ed play in it? Because I actually have it on here. So is it more secondary or tertiary? Or can it be both?
Tertiary is already when something's already happened or in place, so would it be more secondary then, I would think?
Okay.
I would say both because they can still be practicing driving at home with a parent while they're learning.
Mm-hmm. Exactly. Yes. So some of those interventions is kind of like that gray area. And so, yes. And I thought about that when I actually put it on the slide. So yes. All right. So you all did actually have a question. I know on exam 1, I can't remember the exact question, but it had one part of the intervention was actually secondary and the other part was tertiary. I can't remember the exact question, but it was supposed to be rewritten, but it didn't count against you though. Do you remember that question? Anybody remember that? But yes, so, but anyways, it didn't count against you though. But yes, so some interventions can kind of be, just depends on the rest of the scenario. Just depends on the rest of the scenario. Okay, so good. Thank you all for sharing with that. So the Nurse Practice Act, what's the purpose of this Nurse Practice Act?
Is that the rights the nurse is supposed to follow as far as duties and what's expected? Is that it, or?
That's part of it. But what's that over, because we're supposed to do certain things, practice within our scope. What is that overarm, that one word that we can say that it actually does?
Protect.
Protect. Exactly. Nurse Practice Act is supposed to protect us, the public, the people that we're taking care of. It serves to protect the public and us. So it does set those minimum qualifications, like you just mentioned, Ms. Combs, for nursing in relation to skills and competencies. Each state's scope of practice, you will have to actually look at your state's scope of practice to see what your do's and don'ts are. The state's duty to protect those who receive nursing care is the basis for the nursing license. Because different states require you to do, once you get your license, to maintain those licenses. They have different requirements, and it is state by state. So for those of you that will hold those multi-state licenses, you have to ensure that you are meeting all the requirements for each one of those states. And at the end of the day, the Nurse Practice Act is to protect, to ensure that we're providing safe and competent care. So I do have this little website here, and I can place this in the chat as well. So we know everybody's from different states, and I may already have this one pulled up. Let's see. So, and this is the website that you can actually go to inquire about what is specifically what your Nurse Practice Act actually tells. So find your Nurse Practice Act. On this site here, you can actually go in, and I'll put the link in the chat, and I'll share these links too in the course. After the video converts and I post a recording, I'll share these links too. So you would just go right here and then select your state. And then where are you all from? What state are you all in? Just give me a state you all.
Virginia.
Virginia. Let's see where you're at, Virginia. There we go. And then it has your Nurse Practice Act and then your rules and regulations. So this is a good website because that's what you are governed by, and that's supposed to be your guide. But at the end of the day, all that's in place, the Nurse Practice Act is in place to protect. It's to protect. And I just wanted to show you all that site, and I'll place the link there as well. I put it in the course room. So I have these 2 short videos, and keep in mind, we're talking about the Nurse Practice Act and is there to protect. So I want to hear from you. Let me share my screen here. And I'm just not sure if you all have heard about this, but let's go here. And share.
The Justice Department, Sanic brought down a massive scheme to sell fraudulent nursing credentials, saying there were more than 7,000 bogus degrees. Andrew Dimbert is here with the latest. Good morning, Andrew.
Good morning, Michael. When you hear of healthcare fraud, you might think of phone scams or phony medical bills and procedures, but this is far more sinister. Federal agents say they busted an operation selling fake nursing diplomas. This morning, authorities warning healthcare facilities across the country after taking down a massive coordinated operation they say sold more than $100 million worth of fake nursing diplomas.
When we talk about a nurse's education and credentials, shortcut is not a word we want to use.
Dubbed Operation Nightingale, federal officials say they've uncovered 3 nursing schools based in South Florida, which they say allegedly sold more than 7,600 fraudulent diplomas for about $15,000 apiece.
We're looking around at $114 million paid for these documents.
In some cases, the students allegedly using fake diplomas to obtain nursing jobs in other states without proper training.
When we entrust the life of an elderly parent to the staff of an assisted living or skilled nurse facility, the last thing we want to learn is that the nurses administering the medication, the ones charged with carrying out doctor's order, took shortcuts on their clinical training.
Authorities charged 25 people in the scheme across multiple states, including Florida, New York, New Jersey, Texas, and Delaware. Agents say they've identified several facilities where people may currently be working as licensed nurses after obtaining their jobs illegally. Investigators are now working with licensing boards in each state to make sure anyone who got a fraudulent diploma no longer provides care.
To date, we have not learned of nor uncovered any evidence of patient harm stemming from these individuals potentially providing services to patients.
And officials say about a third of those fake diploma holders could still be out there practicing right now.
The Justice Department, Sanic brought down a massive scheme to sell fraudulent nursing.
Okay, so let me hear from you. So what's out from that video? What's our understanding of what actually happened?
Well, they either didn't finish school or didn't go to school at all and got a diploma for it. They just paid to get that piece of paper. So
Professor, did they still take their licensing exam?
Say that again, Ms. Gunn.
They took their licensing exam?
That's
and
the next. That's the next thing I was gonna say. Okay, so just because you have a diploma, does that mean that you become a nurse and someone hires you? You're right. Even though you finish school, the next step is taking that exam. So this is going to be deeper than just a school giving away diplomas, selling diplomas. How did they set up and how did they get into in order to take these exams? I'm sure they took an exam. So now this is a whole different can of worms. So what could have potentially happened there?
I feel like they just sent the paperwork to the Board of Nursing as if they actually went to school, but lied about them actually attending classes.
Okay.
So that's what I feel like. And I feel like some of them who passed, I feel like they had some kind of experience in the medical field, even if it was like a medical assistant, an LPN, or a CNA. For them to pass the state boards, I feel like they had to have some type of experience.
Or what else could have
already
potentially
did.
happened? Or what else could have
Oh.
potentially happened? Think back about the ACT scores, and those students and parents. Do y'all know that story? Think about that. What else
Mm-mm.
could have
Oh.
potentially happened?
Mm.
They probably knew somebody at the
They paid
border
for a
nurse.
score.
And I forget what they called it, but some of the, the I guess the movie stars or whomever, and you all correct me if I'm wrong, they were some kind of way paying, it was some kind of operation where they were paying to have their students ACT scores being like almost perfect, or SAT scores. And they were the children were going to take these exams. Like, how were they passing?
That's
Sometimes it was,
crazy. I never heard of that story.
oh yes, there are some of them
There's
are
a Netflix documentary.
yes,
wow.
some of them are actually doing prison time because
Oh my gosh.
yes. And
I'm
it's
gonna
like,
have to look that up.
how did they actually get, because just because you have a diploma does not mean that you can go and fill out an application. They're gonna want to see your license. So an exam had to be taken at some point. How were they allowed to take this exam? So this story is going to be deeper, bigger than just that nursing school saying, hey, you have a diploma. It's going to be at those board of nursing, the people that allow these people to take these exams. Yeah, they might have had some prior knowledge. Some of them might have, but not everyone probably had experience as being a MA or a PCT or a CNA. So how were they able to sit for the exam and pass the exam? We should have had people to go to nursing school for real and still have never passed the exam. So what could potentially, I don't know, I'm just thinking, what could have potentially happened? That exam was, those answers were leaked. Had to have been. And then
There's also a lot of resources out there for studying for the NCLEX. So instead of like attending school, maybe they only studied for the NCLEX.
okay. Again, there are plenty of people who went to school and used those tools, UWorld, ATI, and they still haven't passed the exam. So I'm saying that to say it's probably going to be ugly once they get, down to, and I'm hoping that no one at the board of nursing in those states allow that to happen, but we don't really know, but it's something. So again, we're supposed to be protecting. Any other comments? Okay, and one more video here. So, for the last couple of years, we have been the most trusted profession. I want to say at least for the last 5 or 6 years, nurses have been. And so, we're going to hear a lot of, are your license real? We're going to hear that. So just expect that. And I guess it is kind of reasonable, being that they had Operation Nightingale. Okay. So again, we're supposed to be protecting. And I can't skip this ad, you all. But you do see the title. So here we go.
The United States government has detected and is tracking a high altitude surveillance.
Wait a
balloon.
minute. That's something else. Let me go back. And we can talk about that too. I'm not
I
sure.
was just talking about this with my mother, this same incident. We just heard about this.
Yeah, I read about it this morning.
Oh, the balloon?
No, the woman in the body bag.
Oh, okay, yeah. Okay. Yeah, that's what I'm trying to get to. Let me
Yes,
stop.
we were just talking about that.
Okay, go ahead until I can get, I'm having technical difficulties. Go ahead and talk about it. Tell us what you all discussed. What do you know about it?
Well, my mom came to me, she goes, did you hear about the lady that was pronounced dead and put in a body bag, and when they went to unzip it after she went to the funeral home, she was alive?
Exactly, you all. That's what essentially they says what happened. So this video gives a little bit more detail. So Nurse Practice Act, we're supposed to be protecting, providing that care, not causing any harm.
According to an 8-page report from the Iowa
Wait a minute.
Department of
Go ahead.
According to an 8-page report from the Iowa Department of Inspections and Appeals, a 66-year-old woman was admitted to Glen Oaks Alzheimer's Special Care Center in Urbandale in December of 2021. Just over a year later, on December 28th, she was admitted to hospice care. The report details that just 6 days later, January 3rd, a licensed practical nurse pronounced the woman dead. The nurse noted the woman's eyes were fixed and there was no breath sounds. The report also states the nurse could not locate a pulse and placed a hand on the woman's stomach and felt no movement. A funeral home was called to pick up the woman. In the report, the funeral director said they saw no signs of life from the woman and placed her inside a cloth bag and zipped it shut. When the woman arrived at the funeral home, staff zipped open the bag and found the woman's chest moving as she gasped for air. The funeral home then called 911. When first responders arrived, they found a pulse and the woman breathing, but no eye movement or verbal response. She was taken to the hospital, then released back to Glen Oaks on January 3rd for continued hospice care. 2 days later, on the 5th, she passed away surrounded by family. Lisa Eastman, executive director of the center, released the following statement to Local 5, saying, "We have been in close communication with the family of the resident, and we just completed an investigation by the Department of Inspections and Appeals regarding the matter. We care deeply for our residents and remain fully committed to supporting their end-of-life care. All employees undergo regular training so they can best support end-of-life care and the death of our residents."
Okay, so let's talk about our understanding of what actually happened.
The United States government has detected
So let me hear from you. What actually?
I have a question though. In Iowa, are the LPNs allowed to pronounce? Because in Virginia, we are not.
Good question.
No,
Yeah.
I know we can.
Exactly.
RNs
In Alabama. In Alabama.
I didn't think nurses were allowed to pronounce people dead.
In the
Yeah,
hospital,
LPNs
it's
can't
nurses,
pronounce,
so
so why
why
was that even?
Go on, go on.
I'm just like, why was that even taken into account? Why didn't she call for an RN? Because RNs are the ones that are allowed to pronounce, not LPNs. And you placed your hand on her stomach. What does the abdomen and the stomach have anything to do with anything? It's heart rate, pulse, and breath sounds.
Mm-hmm. Someone else? Thank you.
If it was my family member, I don't think I would let them go back to that same facility. I think I would have had their hospice care done somewhere else.
Okay, that's interesting. They did go back. That family, those family members did let their loved one go back. Go on. What other thoughts?
Where was the second verifier and where was the hospice company? Where was the hospice nurse to verify? I mean, just saying.
Anyone else? I'm not sure if she had hospice prior to or she had hospice after the fact. And so what do we know about hospice? And that's
Well, it said that she was on hospice beforehand for like a week, and then she was pronounced by the LPN.
So what do we know about if a person is in a facility, a skilled facility and hospice, and they're a hospice patient? What does hospice do?
Medication management, bereavement for families, just to make the patient comfortable for end of life care. And usually when they pass away, if you don't have an RN in the building to pronounce, you call the hospice company to send out the RN to do the assessment and pronounce.
Anyone else have experience with hospice, either you in a facility you worked in or your loved one had hospice, which you care sharing? So for the most part, you're right. Even though that person is in that facility, once they receive hospice services, hospice pretty much, for lack of a better word, takes over their care. Everything from A to Z. See, they send CNAs in on certain days of the week to provide those baths for them. Their equipment, they even supply the equipment. Even though that facility has a bed, has a concentrator, they still send in their equipment. So hospice pretty much takes over that care, and any changes that facilities communicates that with the hospice nurse or the hospice company, and they, they communicate that with the hospice nurse and that MD. So many things about that, we're just really not sure about. Yeah. And so the nurse did document, and like you all brought up, in your state, can LPNs, in some states can RNs, can they even pronounce? And so yeah, there's a lot that happened or should not have happened in that scenario. And I know we don't have all the details, but just from a little bit of information that we did receive. So documentation, knowing your scope of practice, those things that you are allowed to do, it is very, very important that you know what your scope of practice is. And even, and sometimes at facilities, they have, these cultures are created with things that are supposed to be okay. But if it's not part of, first of all, your scope of practice, and also if it's not part of that company's or facilities policies and procedures, even though it might be some type of culture that they've created, if it doesn't fall into those two things, you're not supposed to be doing it. And you might have to change a job because you're refusing to do things that are illegal that will cause harm. And or you might be that person to bring it to the administration's attention. Hey, this is what's going on amongst, my team members, my coworkers. This is like this hidden culture that they're saying that it's accepted. But I know, I'm not going to cause harm, and I know it's not the right thing to do. So you might have to be the whistleblower, so to speak, and or you may have to, like I said, part ways, because you don't want to cause harm to anyone. So the next thing on my slide is liability insurance. Some of you all are already nurses in this class, and or you all might be healthcare workers, whether or not that's a CNA or a med tech or whatever. Do you all have liability insurance? Make sure your camera stays on. Turn your camera back on, Ms. Hootie. Even if you have to walk away, remember, because that's 15 points, you all. And I just have to keep reminding you all just so that you can make an informed decision. So do you all subscribe to a liability insurance? And even if you're not working in healthcare, whatever career or profession that you're currently working in, you want some type of insurance. For the most part, nursing schools, for you all going out doing those clinicals, there is some type of insurance that the school has or have for you all to subscribe to. But on your own, if you are working in healthcare, whether or not that be nurse or, like I said, CNA or whatever, you need to subscribe to some type of liability insurance, because things happen. For the most part, it's not that you intentionally did anything wrong, but things just happen. And so that insurance is there to help you out, in the event that something happens. Because we know now lawyers, they're not only going after the facilities, but you yourself actually work. If you took care of a person, that something happened and that family is deciding to sue, they can not only sue you, the facility, but also you as that individual. So liability insurance, for the most part, NSO is a company that provides that liability insurance. Even if you are a student nurse, that you can actually subscribe to it. I think it may be, even if you're a nurse, I think the most that it actually costs is maybe like $125. But if you're like a student nurse, then, or either other healthcare professionals, the subscription may not cost, but maybe like $30 or $35. But NSO, there's another insurance company out there, but that one comes to mind. Okay. So vulnerable population, specifically, tell me about, what do you know about migrant workers? Who are they? What are they? What are those? Where do migrant workers work at? What do they do? Tell me, what do we know about them?
I would think more hard labor jobs or like construction, things like that.
Construction in the field.
Just factory, yeah.
Okay.
Like jobs they get paid under the table with.
Could be. Could be.
Field workers in like migrant and rural areas.
Like a lot of minority groups.
Could be.
People who move to different areas for work.
Exactly. So what are some exposures of migrant workers? So we're saying that they may be working in the fields, they may be out getting paid under the table. What are some exposures? Think about their environment. Think about
Pesticides,
what you say.
chemicals,
Chemicals,
pesticides,
pesticides. Okay. Okay.
just the environment in general, sun, cold.
The sun, I about to say, yep, cancer. Sun.
Good. Good. All right. Pesticides. I think we got heat and cold. What about snake bites and rodents being exposed to? What about unsanitary conditions, crowded housing? For the most part, their work is sessional or seasonal. So that means it's only for that certain amount of time. It's not like a year-long job. And so they're living, they might decide to just all live in this one home because, hey, we're just here for 2 months. We can tough out anything for 2 months, but we're living with 10 other people in this place. And also, if whoever the employer is, if they know that these people are just coming in for 2 months at a time out of a year, 3 months out of time, 3 months out of the year, what do you think they might do with the housing? You think they're gonna do good upkeep to that housing? Is there gonna be running water? They might, but it is a good chance that the employer is probably not gonna, do or keep it up as though if someone was gonna be living there year round. So with that being said, the migrant worker might be exposed to unsanitary conditions, crowded housing, because, sometimes they may say, well, hey, we provide this housing for you and we'll give you a stipend, but the stipend really doesn't cover housing beyond, where they need to actually stay at. So housing might be too expensive. And so they may choose to, well, hey, we just tough it out. We'll just stay here together. And so with crowded conditions, we know that could put people at risk for infection, tuberculosis, things like that. And I did mention heat and cold. And if they are actually working in the fields, like you said, in construction, more than likely they're going to have some aches and pains in their back. And some things that we do want to know, as a nurse, we might want to ask, what makes it get worse, or aggravates that low back pain?
If they even come to the doctor, or most of them won't.
Exactly. They might not even come. And so you might have to go to the people. You might have to go to where they are, provide that education about the exposure to pesticides, about what to do in the event that you are experiencing or get injured or something. Okay. So a migrant worker, for the most part, transportation probably is going to be an issue because remember, they're not at home. They're coming somewhere to do a job for more than likely a short period of time. So they may or may not have transportation. So in the event that they needed to get to an urgent care or a hospital, that might not happen right away because they more than likely probably won't have their vehicle. And the places that they are actually working, for the most part, if it's field and things like that, they're way out, away from communities and away from little towns and things where urgent care centers or hospitals are. So there might be a communication or a language barrier. There might not be an interpreter. So what would you do in that instance? If you were that community health nurse and you went out to that field, that employer called you out to, I don't know, to provide education about something or to provide first aid care. And that person or that group of people, there was a communication or a language barrier and there was no interpreter. What would you do?
Most of the phones nowadays have, the language where you can change. You can speak and it repeats it back in a different language. My phone does.
Good. What else you got?
Ask if anyone else around there can translate.
Exactly. For the most part, it's somebody in the group, more than one for the most part. There's not a language barrier for them. So yes, so think outside the box. Hey, is it someone else here that does speak whatever the language is? And or sometimes communication barriers is not that the person doesn't speak the language. It could be low literacy, that they just don't have an understanding of what you're communicating to them. And so that's a different conversation about a communication barrier. But yes, you can do like a short little conversation or teach back, and you can say, well, okay, this one understands and this one don't. So you might can use that person that do understand, that have a higher level of literacy, to help you translate or help the other person. Good. Thank you all for sharing. What about their immigration status? What does that have to do with anything?
They don't want to get in trouble for being here illegally.
So
they might not go seek health care.
That was what I was going to say. That's the next question I was going to ask. Do you think they're going to seek health care if something actually happens? Yes. Good. Thank you. We do know that in the rural areas, access to health care, there is a shortage. They might have to travel an hour or hour and a half just to get to urgent care or a hospital, or for sure specialists. Poverty is the issue. If they're making money, and they're living in poverty, for the most part, are they going to subscribe or use that extra money to pay for health insurance? So you're right. I see heads going left to right. So more than likely, they probably won't subscribe to their health insurance. Sometimes, even if you're not in poverty, it's like, oh, hey, I don't need that. I'm young and I'm well. That's just not an issue right then. So poverty is not always a reason why people don't subscribe to health insurance. It's just not important at that moment in time. And so for the most part, if that worker gets injured and they are there for a season, a couple of months or so, is the employer going to provide benefits? Are they going to have sick leave and vacation leave? More than likely not. So if something happens, they're probably just going to tough it out. They're not going to try to seek health care, because if they're not at work, that's a loss in pay. They don't have leave time to take the place of it. So immunizations, if they're moving around from place to place, are they going to have is a medical record something that we all just have in the backseat of our car, in our suitcase? So that continuity of care. Go ahead, Ms. Gunn.
I wasn't saying anything.
Oh, okay. I'm sorry. So that continuity of care is not going to take place, because, even, we are not traveling around place to place, but some things we just don't remember. Like, oh, I think I got all my, my vaccinations. But if they don't have that medical record, because, this is not where they live at, then that continuity of care is not going to take place. So when we talk about vulnerable populations, this should be up under here. I was rearranging my little PowerPoint. So vulnerable populations. So which populations are at the highest risk?
The families with children.
Children and elderly.
That we say the very old and the young. And then who are some other vulnerable populations populations of people that we've identified that are vulnerable?
People that's sick, they have some kind of illness. The elderly.
Yes.
Homeless.
Like
Homeless, yes.
homeless and living in poverty.
Veterans, but the groups of people, the population that they deem highest risk are children and minority racial ethnic groups. So this is a testable concept here. So all of those are vulnerable populations that you all have named. Homeless, people that may have a chronic disease process, veterans, but the ones that they deem as highest risk are the children and the minority racial ethnic groups. Okay, and so let's talk about pregnant teens and their children. What's a long-term goal for a pregnant teen?
To keep going to school.
Keep going to school and complete that education. So what are some short-term goals?
Healthy pregnancy.
Mm-hmm. What else? Short-term goals. Healthy pregnancy. So we want to teach them about the folic acid, the prenatal vitamins. We might even, provide education. You may have some new mom classes, new parent classes, contraceptives. Go ahead.
I was getting ready to say contraceptive, but you said it before I had a chance.
Okay. Good deal. All right, so we're gonna change gears here. We're gonna move forward to week 4. And I'm going to share here. So we have specialty nursing, rural health, faith nurse, hospice nurse, and the home health nurse. Anyone has worked in any of those areas and care to share any information about that? Anyone work in home health, hospice, or faith nursing?
Dolores is talking, but we can't hear.
Dolores, unmute.
I worked in home health when I was an aide. I didn't like it.
What was challenging about it?
The patient that I had was decent, but her daughter was not the greatest to get along with, and she that made it a little bit more difficult. So I just had to stop doing that case. And then another case I had was an older lady, and she lived in like one of those elderly communities. But her son was living there with her, but they moved like closer to, I live in Newport News, Virginia, but they moved up to Williamsburg because the daughter lived in Williamsburg. So it was like I was taking care of her and the son, but I was only supposed to be there just for her. So home health is just not for me.
Anyone else have any experiences with home health? Faith
Yeah.
nursing? Go ahead.
Yeah, I've done home health, hospice, and then I did insurance visits all across the country. So I go into homes, mostly Medicaid and Medicare. Some PPO plans, but it takes a special person to do home care. I don't mind it, but you just never know what you're gonna get. You never know what you're gonna walk into, and you have to know what resources you got. So
Exactly.
Yeah.
The community nurse, public health nurse, autonomy, those resources, identify, thinking outside the box, establishing those interdisciplinary team members, having their phone numbers, reaching out. You have to because you just never know. And everyone is living situation is different. Like you all just said, you were taking care of the patient, but then the son was there. So it was like you had 2 patients. And so you might encounter, water, no running water. You might encounter unsanitary conditions. You just never know. All right, here's a video I want to share.
My name is Chelsea Wilson. I am the clinic manager down here at the Wayne Community Health Center. I'm excited to kind of show you guys what a day in the life of a rural nurse means and is all about. Bignell is located in southern central Utah. We have a population of about 200 to 300 people. We have the mountain in my backyard, and we get to take full advantage of that on our day off, or after work one night. We can head out on the mountain and go fishing and spend the afternoon with the family. And I think that that's important for anyone, is to find things that they love, but living in such a beautiful area and being able to do that on a moment's notice is freaking fantastic. And we don't have traffic. The kids can play in the road and we don't worry about them. I was born and raised in Richfield, which is just over the mountain, another rural town in Utah. and met my husband, and he lived here. And I don't know if you guys know about boys that live in rural Utah, that it's hard to get them out of these places. So we moved here, and it's amazing. It's unlike anywhere I've ever been. You know we love the people that are in our communities. So as far as work goes, as far as medicine goes, I think for urban nurses, it would be really surprising to understand exactly everything that you get to do in rural nursing in a clinic like this. In the city, you're generally just at one area. You're in the ICU, or you're in the ER, or you're on med surg floor. Where here we get to be able to do a lot of things, a wide variety of items, that's not just stuck on one thing. We really do work at the top of our licensure, and we have a full functioning lab. We dispense prescriptions out of the after hours pharmacy on Saturdays and after hours. We have the dental office. Then we have our medical clinics, mental health. We bring in vision, we bring in orthopedics, we bring in chronic pain management, obstetrics. We have nurse midwives that come over, and then we do our primary care stuff as well. It's not unusual for patients to come here for their well women, and we're bouncing their baby while we're working. So, I mean, it's just kind of how it works around here. There's not a typical day in rural nursing. You never quite know what's coming. So we'll often have a day where we see an OB in the morning, and then we're walking somebody through the end stages of their life next, and then maybe a baby, and then maybe a code. I run on the ambulance on Mondays. I spend time in my community, where in city settings, you probably wouldn't get a lot of that. Not very often do you go from the clinic to the ambulance to flying a patient out. So, I mean, it's very dynamic. In rural healthcare, we see a wide variety of things. We live right on the rim of a national park, and so we see car accidents or falls, as well as our locals, medical emergencies. Our closest hospital is about an hour away. And so we really have to rely on our staff here at the clinic to be able to take care of patients and stabilize them until we can get them to the definitive care. We currently own 4 different medical locations, one in Salina, one in Hanksville here at the Bignell Clinic, and then one in Escalante. Hanksville is about an hour away, and if anyone's ever been to Hanksville, they know that it's a whole different world down there than anywhere else in Utah. There's not a lot of resources for patients down there. We go down there once a week, but we're often helping patients get arrangements for rides. We've had patients who don't have heat in their home or running water that we've had to help beyond just the medical side of things. Thank goodness for some of our support here at the clinic that we're able to do that. So it's extremely rewarding to be a nurse in rural healthcare, because you are treating people you know and you love, but then you're also changing people's lives that you probably will never see again. Tourists that have been here. I have a lady from Germany who I still keep in contact with, who had an open fracture to her ankle, and we talk on a regular basis. We've built those relationships with patients. I mean, it's not unusual for us to treat our grandparents or our husbands or our in-laws. We also will see someone in the clinic, and then later that day we see them at the grocery store, and it's a whole different dynamic at the grocery store versus the clinic. And so we do really develop relationships with our patients on an intimate level, to the point where you even go do things sometimes, and then you see them in the clinic the next day. These are people that we know and love. So in rural healthcare, because of how small we are, we really work with our family. They're not legitimately my family, but that's how I feel about the people that I work with here at the clinic. They're the people that I truly love and would do anything for. They dedicate their heart and soul to this place and to the patients that we serve. We've had staff drive patients to their appointment. We've had staff deliver food to people when they're sick. We've had staff go to their home and evaluate them, although they know that we're not able to get reimbursed for that. So they really do put their heart and soul into the patient and into the care that they provide here at the clinic. in rural healthcare, we have a lot of autonomy. We're very limited in our resources. And so that allows us to be independent in how we make decisions. Our providers give us a lot of freedom to work with their patients and understand their patients and come to them when we know something's not quite right, like we do in chronic care management or transitional care management, and see patients. We're kind of their eyes and ears of the providers when they're not available because they're so busy taking care of other things that their nurses really have to step up and be able to independently judge what's going to be best for that patient and then make sure that the provider's looped in on that. So it used to be that nurse encounters weren't billable, and now we've understood ways to bill for nursing encounters. Chronic care management is one way. In clinic settings like ours, in community health centers, it's a little bit different than other independent facilities, but you can bill out for the time that you spend with your patients non-face-to-face. And that's pretty rewarding to have a type of an encounter that Medicare recognizes and is reimbursing the clinic for. I hope that eventually someday we can get to where Medicare will recognize for all nurse visit types. You know, when patients come in for an annual wellness visit, that the nurses can do those completely independently without having to consult with a provider because they really are within our licensure. Right now, we have to consult with a provider in order to bill for them, but eventually, hopefully Medicare will recognize that and let us do those independently. I went from being an MA EMT to RN and now onto a DMP. And I really feel like my community and the staff that I work with are cheering for me and encouraging me to go on and encouraging me to work really hard and achieve my goals. And that's so important. I think it's great when you have that many people rooting for you. The community is really a community. They say it takes a village to raise children, and we have that here. What would I tell somebody who was moving here? You're gonna love it. It's the best.
All right, so what's some pros to rural nursing?
It seems like a very fulfilling role.
Other pros, what are some pros to rural nursing?
They have their own little pharmacy and like dental office and everything right there.
Even though they're pretty much having to run it and staff it, is right there though. Yep, that's good.
You get to know your patients well.
Mm-hmm. Yes. Talk about establishing that rapport and trust. Yes. What are some other pros?
Sounds like the doctors give them a lot of freedom to make the choices and decide for their patient what's the best treatment option.
Okay. So let's flip it. What are some cons to rural nursing?
You don't always
lack
have
of
every
resources.
resource.
What else?
Like in her video, she said the closest hospital was an hour away. So it's just getting like that immediate help and accessibility.
Exactly. Too much autonomy. It's like, okay, I need some help with this right here. Exactly. Good. What about just privacy? You know, everyone knows everyone. The same person that you just took care of, you see them at the grocery store. They might be the same person that's going to be at the event that night. Just, you know, the privacy, lack of privacy. Anyone interested in moving to a rural area and providing that care? We do know there are all types of programs out there that encourage healthcare providers from A to Z to move to rural areas and for the most part, they help take care of some of your education expenses. Even if you're currently in school, they do have programs out there that you can apply for. And if you get selected, they'll, provide housing, also provide you a stipend. There are all different kind of programs out there because those things are limited. Access to healthcare is limited. And another thing that we're seeing too, the specialists, they are selecting days of the week where they will actually come into the largest town or the closest largest town and do a clinic on that day. It might be just 2 days a month, but we are seeing a lot of that as well. But the need is there. So what do we know about faith community nursing?
I would kind of think that's more of a specialized practice, right? I mean, that's how I would put it.
Okay, so it is a nurse that has specialized care or specialized knowledge about faith, no matter what the congregation is. What else? What else do we know about faith nursing? Okay, let me go ahead and play this video for us.
Sharon Clohesi's world was turned upside down by one phone call when she discovered she had both a hole in her heart and breast cancer. Unemployed and uninsured, James Dobson's high blood pressure was life-threatening. Shortly after Karen Houston's husband suffered a nearly fatal brain aneurysm, her daughter was diagnosed with diabetes. Unable to sustain her oxygen levels, Lily Jaquetti spent more than 1 month in the hospital. Though these people were dealing with devastating illnesses, they did share one advantage. They each turned to their parish nurse for support. Across the country, parish nurses practicing the specialty of faith community nursing are improving public health by reclaiming the historic roots of health and healing.
This is your bubbler. How often do you change the water?
I have to change it every day. When Mrs. Lily Jaquetti was hospitalized for nearly a month, parish nurse Ramona Davis made daily visits. My illness was really serious, and everybody knew it.
I visited with her. I followed up and explained a lot of tests that she was required to get that she really didn't understand. When she was ready to be discharged, I made sure she had her equipment. She had visiting nursing. She had her oxygen set up. 128/70. That is really good. You are doing such a wonderful job. Yeah, sure.
There are a lot of churches in our neighborhood, but there's only one parish nurse. And people will come in, they'll leave other churches and stop by to see Ramona. I wonder how in the world I could have done ministry without a parish nurse.
So I'm going to give everybody a handout.
Ramona's duties range from assisting the critically ill to supporting church activities and promoting wellness.
I do a lot of health teaching with the kids from the school and the confirmation kids at the church. So we're going to look at it from a religious standpoint. We currently have a gospel aerobics class, which is intergenerational. We get to interact with people on an everyday basis. If there's a change, you notice it. How was your blood pressure the other day? Okay.
It was 135 over to 85.
Oh, okay. You have these long relationships with people. Okay, take a deep breath. I've known some of the people that I care for now
a good part of my life because this church is where I was raised.
These long relationships enable parish nurses to treat the body, mind, and spirit. When Karen Houston discovered her husband had a brain aneurysm and her daughter was a diabetic, she questioned her faith and her ability to cope.
I thought I was going to pass out. You know, like I had to have some place to sit down. I probably would have had a nervous breakdown without Michelle. Nurses do have one step in the sciences and one step in the humanities. And I think parish nurses also have that other step in the spiritual through this holy anointing. May God's love. We're Christians, and so, you know, they have someone who I could relate to on that level and could offer that support and prayer and that kind of thing. Just help me get through a very difficult time.
I firmly believe that the spiritual side of health is a very important aspect for people at any time, even when they're seemingly healthy. Parish nursing is in a position to really bridge and look at both the physical health and spiritual health of people in the community.
In communities with few resources, parish nursing is a critical lifeline. Joe Kujawinski connects people to the resources they need to regain their health.
The needs here are really overwhelming. I often think of this parish nurse ministry as being, if you think of it in terms of hospital nursing, that this is the intensive care unit here. You know, if you see someone with a terribly high blood pressure, you think, oh, that must be the problem. Well, it is the problem, but that person may really want a pair of clean pants. Thank you.
James Dobson hadn't been to the doctor in years. He was shocked to discover he had high blood pressure, and he was reluctant to take the medication because he feared the side effects.
As time went on, his blood pressure was literally going up and up and up.
She instilled in my mind to, like take the medication every day. So on some days I forget, and then like an image of Joe jumps up and hey, back upstairs, I go to get my medication.
We averted a stroke for him because his blood pressure was quite high. It's surprising sometimes how much sodium is in the canned goods.
So with our parish nurses, we have an opportunity to act on those illness prevention opportunities and prevent individuals from being seen in the emergency room or having to be admitted to the hospital. So it's a wonderful way of promoting health and containing healthcare costs and also fulfilling our faith-based calling.
Parish nurses are involved with community activities that range from preschool classes to women's support groups.
The movements are scripture and meditation and then sharing.
Parish nurse Deb Stankiewicz first met Sharon Kohesi 10 years ago when her children attended Deb's health education classes. The long-standing relationship between Deb Stankiewicz and Sharon's family proved itself indispensable when tragedy struck.
I found out that I had a hole in my heart and breast cancer through one phone call from my doctor. So I had 3 surgeries in 1 month.
Parish nurses empower people to get the information they need to make informed decisions about their health.
And when I knew she was going for the appointments, I just called, keeping in touch and offered, if you would like, I'll be happy to be with you in those appointments to be a second set of ears because you are absorbing a lot of information at one time. Like, family history might be a piece of this that she should consider because she does have her mom and an aunt. Deb's such a wealth of information. And to have her along at the visit, she could ask questions that didn't ever occur to me to ask. I do think to have a nurse in the church that can help you to sort things out is a great resource. On earth as it is in heaven. Give us this day our daily bread.
As America ages and healthcare costs spiral, parish nurses are becoming an increasingly valuable resource to communities and congregations across America.
When we surveyed our congregation before we embarked on the $3 million capital campaign, the thing that our parishioners told us was most important to them was the parish nurse. I think all churches should have parish nurses.
Okay, so what are some cons to being a parish nurse? Are there any cons to being a parish nurse?
And the only thing I can think of, they do spend, it looks like a lot of their time because they're helping so many different people in their parish. So just like she went on the visits with them. So, and they might not look at it that way. I mean, you know, but there is a lot of time spent.
So we are creating a job description for the parish nurse. What are some activities and things that we will list that that parish nurse, that's going to be a requirement for that parish nurse? What we list on there? Parish nurse, you need to expect to do the following. What are some things?
Maybe run support groups.
Okay.
Like summer camps and stuff.
Mm-hmm.
Education.
Education, exactly. They did pretty much everything from A to Z in that video. Parish nursing is a whole different setting. And again, you are autonomous. You know, you have to think outside the box, but it is there. Okay, our last video is about hospice.
No pain to your back anymore. No pain to your back anymore. You haven't been having to take your pain medicine.
No, there's no time limit when she's here, and she always makes sure that I'm comfortable and not in pain.
I guess I had my first hospice patient at my first nursing job. I really seemed to help that patient and their family. When the patient passed and the family came up to me and hugged me, crying, saying, "Thank you so much." You don't really get a lot of that in nursing. I was kind of drawn to hospice from the very beginning. So a home hospice nurse goes into the home and assesses the patient and assesses the family to see what kind of needs, whether it's medical, emotional, any outside support that's needed.
That's cute.
It's cute. If you can help somebody in their very last hours, days, months, that's kind of the best gift you can give for somebody and their family as well.
Sounds make them meditate.
I enjoy all the relationships I build with this job. I feel like I really get close to all my patients and their family members. My favorite part of the job is all the people I get to meet. And my favorite part of the job is when somebody passes and they're comfortable and their family is okay with it and their family is comfortable, because that's a hard thing to do.
Aww, they take everything.
As a hospice nurse, I have I have seen and heard a lot of things that have changed my spirituality and make me feel like there's always somebody there waiting for you. I always had hospice in the back of my mind ever since my first hospice patient. And since my first day, my first patient, has just been, this is where I belong. My name is Sarah Turner, and I'm a Gilchrist home care nurse.
So nevertheless, all the settings, they're providing that hope and that care, you know, whether it be a conversation, whether or not it be that conversation or actually doing a procedure, they're providing hope. There are so many settings. The beautiful thing about nursing is there's so many settings, and there's just not one job description. There's not just one list of activities or tasks that we will be held responsible for. It just depends on the setting. And it's just a beautiful thing. So any comments about the hospice nurse? Are there any comments? Any of you are interested in being a hospice nurse?
Never really thought about it.
Mm-hmm. All right. So our next activity is, again, it's going to help us understand the concepts for this week. And I've just shared a link in the chat. If you would go ahead and click on that link, and I'll provide this link also in the course room, because we will not get an opportunity to finish the Jamboard while we're here. But let's just go ahead and click the link, and let's at least do the first, maybe the first and the second Jamboard. Let's see here. Let me share my screen. So if you would go ahead and click on the link, and the Jamboard is just to reinforce the concepts in a different way. Are you all familiar with Jamboard? Okay, so it's just a huge sheet of paper or a whiteboard that a concept is listed on, and we talk about it, but we talk about it in writing. So click the link. Once you click the link, there are actually 13 different slides here, 13 different boards. Each one has like one question or a concept on it. And it is just to reinforce the concepts that we've talked about. So what you do is, once you click the link, you actually click the sticky note. It's right here to the left. Click the sticky note and place your name on the sticky note, and then respond to the question or the comment that's there. So we're going to pause here and give you all a few minutes to access the Jamboard. Click the link that's in the chat box. Make sure that you place your name on your sticky note, as well as your comment, responding to the concept. So place your name and your comment, responding to the concept that's there. Here. So Jacob and Brandy, I do not see your comment. And maybe you have more than one sticky note, maybe. If not, just delete it and just rewrite it. So the first concept that we want to ensure that we do have an understanding of, what are some pros and cons of rural healthcare and nursing? Rural healthcare in nursing, I should say in. So be sure to put your name, because we want to give you credit for doing, for participating. So make sure your name is there. You can do first. I think everyone has a different first name. So first name will be fine, but make sure you put a comment. So Dolores, Diane, Hannah, you all go back and actually put a comment. So place your name on the sticky note and whatever your comment is. So we're talking about pros and cons of rural healthcare in nursing. So Brandy has close relationships with patients. So I think that's a pro. So I'm gonna put the pros over here. Uh-oh, trying to move your sticky note. Okay. Rachel said forming deep relationships with clientele. I think that's a pro. Hannah says good relationships with patients. Not good enough resources available. Okay, so she placed both, so we put that one in the middle. So yes, you can place both pro and con on the same sticky note. That's fine. Cheryl says not having privacy because you see everyone in the area outside the office. So that would be, we'll put this over here as a con. Okay, Megan says not having a big hospital near. Okay. Amy says limited resources. Tanya, okay, yours is right here. Okay, pros, pharmacy in-house. Good. Not sure how they do that as far as their insurance though, but I'm sure they figured it out. Because you know, some medications you need those prior authorizations for, and it might just be a, you know, a certain kind of medications. It might not be like a, you know, all-inclusive list. Okay, so good. I'm not sure who's helping me move things around, but good. Go ahead and help me out. Limited access to healthcare. We'll put this over here. Laura says autonomy and then limited resources. So we'll put you right here in the middle. Jacob working closely with the community and then low on resources. Yes. Forming those close relationships. Kinsey, would you say? Pro vast variety of care. Yes, you're just not limited to seeing the same thing over and over again. But what that also entails is you increasing your knowledge about different things that you might actually see. Okay, I think we got. Okay, so let's go to the next one. We have just we have like three more minutes. Let's go to the next one, and you just click the little arrow at the top. What are some of the health concerns of women and children in rural areas? In reference to mental health and then at-risk vulnerable populations. So ensure that you place your name on your sticky note, and you might have more than one sticky note. That's fine. So ensure that you answer and interact and post a sticky note on each of the 13 slides. We've just completed one, and we're working on number 2, and this is going to take us on out to the remainder of our class time. We have 4 more minutes. So this is an activity to just reinforce the concepts, your assigned readings, and just to ensure that, you know, you have an understanding of it. So I'll be quiet and let you all finish this one. Be sure to place your name on it. I'm not sure who did decreased access to prenatal health. You probably can go back and put your name on it. Be sure to place your name on each of your sticky notes so that you can get credit for participating. So it is a requirement that you complete a sticky note for each of the 13 slides. Also, ensure that make sure that you read your classmates' responses, because we do know the more that you review a concept, you master that concept for the most part, 87%. So just that repetitiveness It is good for you. So when you are faced with it on an exam and or in the real, in a clinical setting, or when you go out to do your, to work in your different settings, you got it, because we have went over it and went over it. So just to be clear, we have 1 more minute before we end. You have 13 slides that are part of this Jamboard. You are being asked to respond to each slide. Place your name on a sticky note and your response. Go ahead and make sure you read your classmates' responses as well, because you may not have thought of something and like, oh, wow, didn't really think of it like that. And at the end of the day, it reinforces your concepts, which also prepares you for your exam, your unit exam, and also your HESI and the bigger exam, that NCLEX. Okay, and I'm going to stop sharing. Are there any questions before we end? We have about 30 seconds left. If you have not placed your name and your campus in the chat, be sure to do so. Oh, how do you make your sticky notes? Let me go back to that screen. I just saw that question here. Let me share my screen again. For those of you that are comfortable and understand how to use a Jamboard, you can go ahead and log off. Have a good weekend, and we will see you all on next week. In the event that you need tutoring or to review the previous exam, please reach out. So the sticky note is right here on the side. It's this square right here. No, it's not. I'm sorry. It says sticky note. When you hover over this little square with the 2 lines on it, you click it and a sticky note pops up, and then you just type using your keyboard. And then when you click save, it places the sticky note on the Jamboard.
Do we have to go to this website?
Yes, you have to actually click the link that I provided in the chat, and I will also provide it in the course room. And it's just part of your Gmail. It's safe. It's not like a site that you're going to. It's one of the resources that Gmail provides. So how you get access to it? Yeah, I placed it in the link in the chat, and I also will place it in the course room. So you just click on the link and it'll automatically just take you to that screen.
Thank you.
You're welcome. Have a good night. You all be safe, and we'll see you all next week.
Thank you.
And I had a question.
Mm-hmm.
How do I was trying to see if I can like do like something to the exam, the questions that I missed.
So yes, you would just send a email to me so that we can set up some review time.
Okay, I had sent a message. I wasn't sure if you had got it or not, but if you want me to, I can resend it.
Okay, yes, because I must not have received it, because I've met with students and so I didn't receive it, or I just may have overlooked it. Yes, I do apologize for that. Yes, so just resend it so we can communicate, so we can set up a time that's best for you and myself.
Okay, thank you.
You're welcome.
So we do all 13 slides, right?
Yes.
Okay. All right. Thank you.
You're welcome. Ms. Kershaw, did you have a question or a concern? If not, I'm just gonna go ahead and end the Zoom. Are you okay? You okay? Okay. All right. Take care.